Brooklyn Independent Television.
Hello and welcome to Brooklyn Elected Officials. I'm your host, New York City Councilmember Dr. Mathieu Eugene, and today I'm joined by Dr. Rabin Rahmani, Director of Medical Education and Research at Maimonides Medical Center.
How are you?
Good morning. How are you?
Good, good. Thank God. Thank you for having me.
You're very welcome, Doc. Dr. Rahmani, let me first and foremost thank you. I know you're so busy, especially for being on a gastroenterologist. I know this is a very busy area, and I want to thank you on behalf of all the viewers for coming today and to provide so many vital and important information about gastrointestinal disease and also screening also. Thank you so much. But before we start, would you please introduce yourself and let our viewers know exactly who you are, what are you doing?
Sure, absolutely. Thank you for having me, and thank you for all of your hard work, on behalf of the Brooklyn community, especially in healthcare-related things. My name is Robin Mamani. I am a gastroenterologist. I'm also the Director of Medical Education and Research at Maimonides Medical Center for the Division of Gastroenterology, and an attending physician at Brooklyn Gastroenterology and Endoscopy, based out of Sheepshead Bay. And the majority of what I spend my time with is really both clinical and research-related things in the field of gastroenterology. As you mentioned, it is a busy specialty. It is a specialty that has a lot of procedures, one of which is probably very well known, colonoscopy, which we'll talk about a little bit today, but a lot of other very interesting things also. Very
good, but we're talking about the gastroenterology. Some of the time we mention cardiology, respiratory system. Would you please briefly, talk about when we say gastroenterology, what part of the body we're talking about?
Sure. So it's essentially your entire digestive tract. So it involves the esophagus, which is the food pipe, the stomach, the small intestine, the large intestine, and the other parts that we really deal with, less well known, but just as important, the pancreas, the liver, and the gallbladder. So really anything that relates to the digestive system, all those organs, all the different health-related things are under the umbrella of gastroenterologists.
Very good. So this is the digestive tract, where the food go from the mouth through the rectum.
Exactly. And all the different things that are there, whether it's the pancreas, the liver, the gallbladder, the spleen, that kind of aid in the digestive process. We all kind of just think about food as starting in the mouth and then being digested, but there's a whole gamut of amazing things that happens that really, if any of them, anywhere along the line, get even the least bit dysregulated or don't go as planned, could really have very serious consequences and be very uncomfortable, and symptoms that come along with it. And that's our field of specialty. That's what we deal with.
You mentioned also colon. So I think this is the topic of our show today. What could you say specifically about the colon? I know this is a very important part of the digestive tract. Sure. Could you talk about the colon? What part of the tract represents the colon?
The colon is essentially the end of the digestive tract. It's basically where the food that is digested, where it starts by the stomach and the small intestine, kind of makes its final journey, and where your body is really able to absorb the nutrients, and also fluids, things that are very essential for everyday living. And then obviously, the colon, the large intestine also takes care of the process of waste and getting rid of the things that your body doesn't necessarily need as part of the digestive process. The interesting thing about the colon is, or the large intestine, is that for a long time, people, historically thought that it was really a kind of a tube that just allows passage of waste material to go through. And we're finding out more and more that that's not true. Physiologically, it really has a lot of very, very important and neat and unique characteristics that allow us to get the good parts out of our food, out of our nutrients, and get rid of the bad parts. Or the parts that sometimes may be detrimental, maybe may have negative consequences for the body. So it's really a very unique and interesting organ, and very important organ. One of the things that's also very important about it is, as you know, colon cancer, meaning essentially tumors in the.
But before you go to colon cancer, talking about colon, they mentioned several areas, several parts of the colon. Ascendant, transverse, and descendant, because I know this is very important when we're talking about colon cancer, to identify or to talk about exactly the place where usually we detect colon cancer. You can continue, please.
Sure. So the colon essentially starts, if we keep going along the path of the food, it starts at the cecum. That's really the part right after the small intestine. And then after that...
I think it's on the right side.
That's at the right side, exactly. That's the right side. And then you have the ascending colon. You have basically what's called the hepatic flexure, which is the area right next to the liver. Then you have the transverse colon, which is kind of this large area that goes across the stomach, if you will. And then you have the descending colon, which is the left side of the colon. And it works its way down into the sigmoid, and finally the rectum, where the food or the waste material gets excreted. So a couple of things that people may know as far as screening tests go are a mammogram, which is used for breast cancer. Sometimes different screening modalities are used for prostate cancer. But really, colon cancer and a colonoscopy is a very unique screening tool. And I'll tell you what I mean by that. Colonoscopy is the only screening tool that we have available in medicine today that is not only diagnostic. Meaning, when you go ahead and a person has a screening colonoscopy, again, what you're trying to do is you're trying to find small, what are called polyps. Polyps are kind of like grape-like growths, outgrowths of the skin in the colon that lead to the majority, more than 80% of colon cancers. So what we're trying to do when we do a colonoscopy, by using a very, very small camera to look in the colon, we're trying to find these polyps. So that's the first part of the screening colonoscopy, which is similar to other screening modalities that we have, like mammograms and so on. What's unique about colonoscopy is it's also therapeutic, which means it treats the problem at the same time. The majority of time, when we find a polyp, we're able to go ahead and take it out at the same time, in the same setting. So one test for the patient, one preparation for the patient, and everything is taken care of. And again, by doing that, you're able to tackle the problem before it even really becomes a problem, and prevent those small polyps from going on to becoming cancer. And it's a very important modality for screening, and unfortunately, historically, it's been underutilized. I think with a lot of programs that you're spearheading, like the different screening programs in the community and things like that, people are becoming more aware of it. It's becoming more well utilized. But some of the numbers that you look at show that nationwide only 50%, 50 meaning half of patients that should be getting screening colonoscopies are getting them, which means half are not. Those are all potential cases where, again, a very simple exam could prevent those patients from having, other consequences that they would have to deal with later on.
But Doc, who should be screened for colon cancer? Is there any age involved or disease-related involved? Who should be screened?
It's an excellent question. The simple answer is anybody who's over 50 years old. So there's almost no case where somebody who's 50 years old and older should not have had at least their first colon cancer screening. There are some other qualifications that change it. For example, for African Americans, it's well known that there's a higher rate of colonic polyps as well as cancer. So Because of that, the different societies, the GI societies, as well as the cancer screening societies, recommend that African Americans should be screened at the age of 45, so 5 years younger than the average population. If there's family history, it's well known now that family history plays a very, very important role in people developing colon polyps and cancer. So if there's family history, then also chances are that a person may need to have screening colonoscopy at 40 or younger. So in those cases, especially anybody who has family history of colon cancer, should definitely make sure to speak to their physician, their primary care doctor, and or gastroenterologist to get the right guidelines as far as when they should start their screenings.
How often somebody should have, colon screening? How often? Every year, every 2 years? And also, is there any relationship in terms of, the history, the family history of the person, of the state of the health of the person? Or everybody, they have the same amount of time they got to wait between the first and the second screening?
So it does vary somewhat based on a few factors. So for example, if a person has, let's say, their original screening colonoscopy at the age of 50 and the visualization by the doctor is good, meaning you're able to really see things very well, and you're able to confidently state that there's no polyps, meaning there's no small polyps. So usually in those cases, again, it varies a little bit, but you could wait as long as 10 years before your next colonoscopy. Now, there are cases where there is a large amount of polyps, or where there is a very strong family history, or the physician can't confidently say, based on their visualization, that there may not have been smaller lesions that they may have not seen during the initial colonoscopy. In those cases, sometimes the interval may be less. The follow-up colonoscopy may be required to be done a little bit earlier than 10 years. But as I always said, the important thing is to get the first one. Because once you have the first one, and again, depending on what they find, at least you have the peace of mind of A, having a relationship with somebody who's an expert in this, and B, knowing that you've taken care of your health for something that's very, very preventable.
Colonoscopy, we know that this is a very important screening procedure to detect disease like cancer and polyps. But they still say that it is not only 100% accurate. There's a small percentage of cancer that are undetected, and they even talk about the third eyes, colonoscopy, stuff like that. Could you give more detail about the different steps of screening process or method that we have to detect cancers and polyps?
Sure. So that's actually an excellent point. No screening test is perfect. It's virtually impossible to have a screening test that's able to find 100% of what you're trying to screen for. But that having been said, as I mentioned before, colonoscopy really is the best screening modality that we have, probably for any disease, any tumor, or any other disease state. Some of the things that sometimes lead to not being able to find polyps are, number one, if there's poor visualization. And what I mean by that is that before a person has a colonoscopy, there's a preparation process, which is somewhat involved, but really it's just the course of one day before the test, where a person is given some medicine along with some fluids to kind of make sure that the body is cleansed of the waste material, so that during the colonoscopy, the physician, the gastroenterologist, could visualize the entire colon and therefore deal with any polyps that he may see. So sometimes there are cases where either because of patient issues or because of the preparation, the visualization may not be 100%. And again, in those cases, you may have to make some variations as far as when the follow-up colonoscopy is going to be. There's a lot of new technology that's coming up. Like you mentioned, the third eye. One of the things that we're able to do now is, and again, this has recently come on the market, where essentially we could get, instead of just a two-dimensional view of the colon when we do the test, we could see almost a three-dimensional view. Again, the same way that I'm talking to you, you could really visualize the entire colon, and that really seems to increase the ability to find polyps. And another thing which is very, very exciting, and there was actually a case that I had yesterday, is the therapeutic options have changed over the past few years, where now we're able to deal with large polyps with different advanced techniques that we do, where 5-10 years ago a patient may have required a complicated surgery if a large polyp was found. Now we could go ahead and deal with those large polyps essentially by doing a colonoscopy. It takes a little bit longer, but the patient, again, feels no different for the most part than when they have a screening colonoscopy. So that's really very exciting and something that's changed over the past few years.
Any other technique that they use to screen people, like barium enema, sigmoidoscopy? Do you want to mention those?
Yeah.
And give some few detail about that?
There are other modalities. A sigmoidoscopy is essentially kind of like a half-a colonoscopy, for lack of a better term, where essentially you just look at the left side of the colon. There are some stool tests that are available where basically you try to detect either some gene mutations or blood, or what's called occult blood, which is blood that a person can't see by the naked eye. And those are options in cases where a person, for example, is not a candidate for a colonoscopy due to different reasons, maybe prior surgeries, maybe poor health. But for the most part, I would say more than 95%, maybe even 99% of patients, the best screening modality is a colonoscopy. And again, the reason for that is because you're looking at the entire colon. It's usually a one-time deal. And again, it's therapeutic at the same time. Whereas for the other screening modalities, for example, for the stool studies, if something is found, then those patients would still need a colonoscopy to see what the potential cause of the positive stool test was and to deal with it. So, sometimes it kind of seems to prolong the process a little bit. And again, I always tell my patients, if you're going to the market to buy a car, you're going to make sure to buy the best car that you could afford. So if that's the case, it should be no different with your health, and especially something like colorectal cancer screening, where really it could have life-saving potential.
Talking about colonoscopy, what are the situation people should not go for colonoscopy screening? Is there any situation, let's say this patient, no, we cannot use colonoscopy to do the screening for this person?
So if there are people that have had a lot of surgeries, for example, whether it's, for example, pelvic surgery, again, the pelvis is the area lower down in the body below the abdomen, or abdominal surgery, surgeries that have to do with the gastrointestinal tract. Sometimes that makes it a little bit more difficult to be able to do a screening colonoscopy. And in those situations, that's really a discussion that a person would have to have with their physician in terms of weighing the risks versus the benefits of doing a colonoscopy as opposed to employing one of the other screening modalities potentially. Another possible exception may be somebody who has a lot of medical problems, underlying medical problems, which may not so much preclude the ability to do a colonoscopy, but may present issues when it comes to the sedation. Because again, keep in mind that when we do the colonoscopy, a lot of people think that they're up and they're in pain and there's discomfort. It's not true. There is really what's called conscious sedation, which is medicine given by an anesthesiologist for the most part, usually, that eliminates any pain or discomfort during the procedure. So that having been said, sometimes you have to kind of weigh the risks and benefits of the patient's medical history against being given the sedation. So that's another potential thing that has to be discussed with the physician. But again, for the most part, there aren't that many exceptions to the rule of requiring at least one screening colonoscopy.
What about C-section and appendicectomy?
It's not contraindication.
Okay.
It's not contraindication. If you've had a C-section or an appendectomy, sometimes what happens is, especially if you've had multiple C-sections, you may have scar tissue that has formed over time in the abdomen and pelvis, where the colon lies. So in those situations, it's important to discuss that with your doctor beforehand, because again, it may change as far as which camera the doctor may use in order to do colonoscopy. You may use a smaller camera sometimes, or a shorter camera, and so on. But again, those are discussions that really have to be had on an individual basis with a gastroenterologist. And usually, at least my practice, I think most of my colleagues' practice, is always to find out about surgical history, about any surgeries, including C-sections or hysterectomy, or really any procedures that a patient may have had prior to actually doing the procedure, the colonoscopy.
And in terms of preparation, before somebody go through a colonoscopy, is there anything that the patient should know in terms of eating, drinking, or getting ready for this procedure?
So, again, there are small variations, but for the most part, the preparation entails being on what's called a clear liquid diet the day prior to the examination. So that means that we ask you not to eat any solid food, but we encourage you to have apple juice, water, seltzer, Sprite.
Do not eat solid food, before 3 hours before, 5 hours before.
It's usually the starting. Again, it varies a little bit based on the time that the examination is going to take place. If it's earlier during the day or later during the day, but for the most part, the entire day before is basically you're on a clear liquid diet. And again, Jello is okay as long as it's not red. Sometimes that may confuse the picture during the examination because you may think it's blood, but it's really just the Jello. But Jello is okay. Soup, the broth of the soup is okay, and for the most part, that part people are okay with.
So this is a very safe procedure. We know that, but any medical procedure has some risk also.
100%.
What about the risk associated to this procedure?
That's an excellent question. As you said, the safety is something that really we look at very, very carefully with all procedures, especially something like this that's very common. A couple of potential complications which we always make the patient aware of beforehand is, number one, there could be some bleeding, some small amount, or very, very rarely some large amount of bleeding that takes place, especially if there's a polypectomy of a large polyp. Again, for the most part, nothing is required as far as having to deal with it. Going forward, it's something that stops by itself after a very short period of time, but it's something that a patient may notice after the procedure, and that's something that we always tell them beforehand. There's a very, very small chance of having an infection, whether it's from the camera or maybe from the preparation. Again, very rare, but something that we always discuss with them. And thirdly, very rarely, but again, possible, is that a small hole may be created during the colonoscopy, which would require sometimes, again, rarely, but sometimes small surgery to fix the defect. That's really the most serious complication that we're concerned about, and there's a lot of measures we take to make sure that doesn't happen. But again, like you said, any procedure has some potential complications that you have to make the patients aware of. And really those three are the main complications, potential complications with colonoscopy.
Is there any research that has been done to prevent such a risk or complication to happen? Because the reason I'm saying that, as I told you, I love preventive medicine. Sure. As a matter of fact, I just the City Council just voted one of my legislation, a resolution that I put in the City Council to ask President Obama and also the Congress to invest more money in the research and treatment of stroke. Stroke, this is another area, but stroke is a very deadly disease. Sure. But when we see that, what we can do if we have more resources to detect stroke, earlier, and also to have more treatment of stroke, we can save so many lives.
Absolutely.
But in terms of, endoscopy, and is there any research that has been done to prevent, the risk that you just mentioned?
Absolutely.
If you know.
Yeah. So the important thing
in terms of implementing the technology and.
The important thing, I think, first and foremost, is patient selection. So, for example, in those few cases where you feel that the patient may have had issues beforehand, for example, multiple surgeries, it's well known that in those cases the risk of complications is higher. So one of the things that really has to be done is to make sure that the correct modality is being chosen for each patient. There are patients that I have an extensive discussion with regarding this, and I tell them, listen, I think the chance of what's called a perforation, which is essentially having a defect in the lining of the large intestine or bleeding, may outweigh any benefit that you're going to get from a colonoscopy. So in those cases, again, you have to come up with other modalities that we talked about that may be more appropriate for those patients. The preparation has been shown to really be related to the chance of complications. So when there's poor preparation, it seems that intuitively it makes sense. It's more difficult for the doctor to perform the procedure. So research has shown that the better the preparation, the less chance there is of having complications. And another very important thing is also medications. So for example, there are people that for different reasons are on blood thinning medications or antiplatelet agents. So that's something that again has been shown a lot more recently because of the large amount of use of those medications, that if you deal with it appropriately in terms of discontinuing it prior to a procedure or doing blood tests to see how thin the blood is prior to a procedure, you could decrease the chance of having any complications.
Yeah, and we are running out of time, but the next time we will continue to discuss about it. That's all the time that we have, and I'd like to thank my guest, Dr. Rabin Rahmani, Director of Medical Education and Research at Maimonides Medical Center. Thank you for joining me, and thank you for watching Brooklyn Elected Official.
Watch this and other Brooklyn Independent Television episodes online at brickartsmedia.org/BIT.